Hello, this is Dr. Nick Despotidis, and today I have the privilege of having Academy Co-President Paul Levine with me. We solicited your most challenging practice management questions, and hopefully we'll give you our insight, and by doing so, you'll benefit from it. So with that, we're going to start. Paul, thank you so much for joining us and joining me.
Thank you for having me. I appreciate the opportunity to help out our fellow orthokeratologists. So this is great.
I agree. Yeah, this question is from Jason Bolenbaker. I've met Jason. He's a very seasoned practitioner. So let's get to the first question.
When a patient returns for their annual exam and they wish to discontinue wear, what are your thoughts on fees for transitioning them out of ortho-k? What are your thoughts on fees for adding low-dose atropine in high-risk children?
Paul, do you want to address the first question as far as what do you do when you transition people out of ortho-k?
Yeah, it's never easy to do because, as we know, it's going to take several days for their vision to stabilize, and so first off, we just make sure that this is absolutely 100% what they want to do, and once we decide that that's the case, then we take that long process of washout, and we use some soft lenses to get them through it. But as far as fees and managing that, because it does take time, our policy in our office when we do this is we pretty much handle it like a annual exam with a soft contact lens fitting, standard follow-up. So it's probably maybe hour, maybe 2 hours of chair time total. And so, we make the decision, we supplement with soft lenses, and then we usually see them maybe once or twice, maybe once after a week or so, and then once again after 3 to 4 weeks, and then kind of finalize prescriptions and figure out where we want to go next.
So basically, it's just an hour. How do you come up with that fee? Is there a separate fee to transition them out of ortho-k?
Not exactly a separate fee, but there would be a fee such as like doing a standard contact lens fitting fee is what we would apply.
Okay. I do a similar thing. I look at our office as an orthodontist in a way. I don't do the dental work and the orthodontia for the most part. And I tell patients, usually around college or after college, this is when I encounter this particular issue when someone is in their 20s, they say, Dr. D, I like you very much, but at this point, I've been wearing ortho-k lenses for several years. I'd like to either have LASIK eye surgery or just stop ortho-k. We charge a standard soft lens fee, even though there's a little bit more work. Actually, there's a lot more work, but it's all about the relationship. This is almost like graduation for us. We say, okay, we have to do a soft lens INR because a lot of them have never put in a soft lens. And like you said, it's a somewhat arduous process, a lot of questions. The INR takes at least 15, 20 minutes, a series of lenses for them to transition out of it. And then, we did a study recently of all our patients, and on average, it takes 3 weeks for them to reach baseline, give or take a week. The first week is the most turbulent, and we got it down to a system where we give them single-use disposable lenses, and then about day 4, day 5, the turbulence ends. I usually check them after 3 weeks. If they're having some trouble, I'll check them in a week. And at that point, I say, listen, the fitting is done. I'm going to write a report, and I'm going to send it to your primary eye doctor. And this way they view me as a specialist. It's almost, like I said, a graduation, and it's a nice way to transition them out. And we recoup our time with a soft lens fit. Jason has another question, Paul. What do you do with low-dose atropine? We had a few questions. I know Dr. Roth, Moshe Roth, also asked this question. Do you use low-dose atropine? Give me your insight.
Yeah, I really don't use it very often. The only time I use it is if I have a real young kid in a real high-risk situation, maybe someone 6 or 7 who's certainly they are not at the point that they're ready for ortho-k, or the parents aren't ready and they're already in a -4 or 5, and I'll go to the atropine. But I rarely use it. I find that I can fit either soft bifocal lenses or ortho-k lenses on almost any age. I mean, obviously everybody knows that you can have 40-year-olds that are impossible to fit. So age is not the only barrier. But I do a pretty decent job of getting most of these kids fit into something. So I don't really reach for the atropine very often. But when I do, I pretty much just keep them as standard exam fee patients, and then we do a medical evaluation, about 6 months later, and and then 6 months after that as an annual, and then 6 months after that as a medical. So I'm seeing them twice a year, and I'm billing the insurance because my office does take most insurances still, and I just handle that like more of a standard medical follow-up.
Yeah, that's interesting. I used to do that, and I was trained by Jeff Cooper back 30 years ago, and even then, I think, I may be wrong, he would promote the use of atropine back then, if you could believe it. So I started doing this about 5 years ago, and I got killed because I would, just like you, I would charge per visit, and I would do a subjective refraction, an objective refraction, and basically talk a lot with the patient. So my chair cost was astronomical. It's the same demographic who's interested in ortho-k is interested in possibly an eye drop that slows down their children's eyes from getting worse. So now what we've done is we've come up with a package. It's about 1/3 our ortho-k yearly fee. So for my ortho-k fee, for example, is $3,000, this would be $1,000. And that includes 4 visits for the year. At each visit, I do a history, subjective, objective refraction, and basically talk a lot, because what I found, if I start with 0.01%, that may not be enough, or I may get some side effect of pupil dilation, and each one kind of stimulates more and more conversation with the parent. So we decided to package this. Then I've learned to really go up. If I get good control without side effects, I may go to 0.02. I've gone higher and higher as I've become more experienced with it, until I'm certain that I'm getting pretty good control of myopia progression. So we see them quarterly, and this program is a 1-year program, and usually I reserve it just like you until the child is ready to go into ortho-k lenses. It's just a stopgap. I don't have anybody in this type of program for years, but I certainly have it for a year or so. If I've done the ortho-k consult and I find they're not ready, I said, listen, we have an atropine program. It's an eye drop program. I explain it to them during the consultation. My staff presents the fee, and we have quite a few patients, not a lot, but quite a few patients in this program. Do you have any other things to add to that?
No, I think that pretty much covers that.
All right. Well, Jason, thanks so much for submitting your question. I really appreciate it. Hopefully we'll get some time to chat during the meeting. And I look forward to answering some of the other questions with Paul. Thank you.